Pathology in Oxford with Fiona Powery. Holm then completed his pediatric training in Leipzig before joining the faculty in Oxford, first as an associate professor and now as a full professor in the as a full professor of pediatric gastroenterology. Holm is a clinical pediatrician whose clinical work is based at the Oxford Children's Hospital and at Great Ormond Street Hospital in London. Holm is widely published in our most prestigious journals and is a respected thought leader on using genomic technologies to identify novel genomic defects that cause gastrointestinal inflammation. So I can't think of a better person to give us this talk and lead a discussion today. And Holm's going to tell us about monogenic inflammatory bowel disease genetics beyond rare diseases. So Holm, thank you very much for taking the time to give us this talk and lead the discussion, and we look forward to it.
Thank you very much, Dermot. It's a great honor to present here, and I've seen that many friends sort of are on the talk, Jody and Carl and Alexio. And so what I try to do today is to try to broaden sort of the classical views that we have now in that we have in rare disease genetics. And the classical is, of course, that we identify rare monogenic disorders. And over the last 10 years, this has led to the use of exome sequencing and genome sequencing and targeted panel sequencing, and is now sort of in this clinical application and standard of care. What I like to do today is to take a different perspective and try to go beyond and have a bit of a conceptual view as well. So one of the questions that we always have coming from a rare disease point, and you have from coming from more polygenic view, is of course how much overlap is there in terms of the genes, how much overlap is there in terms of pathways. And if we just take a gene-centric view, what are our candidates, then the overlap is surprisingly low. There are just sort of a small proportion of polygenic candidate genes and even sort of the Mendelian genes where we have sort of common variants that drive polygenic disease and rare loss or gain of function variants that drive Mendelian disorders. Now, what these monogenic disorders have told us is to think about the concept of barrier function, how sort of defects in the epithelial barrier function in monocyte and neutrophil activity to fight bacterial translocation in particular can drive T cell responses, and how defective T cell regulation can contribute to these defects. And similar concepts have, of course, been established by many of you in polygenic variants, where there are interactions in key drivers, as here's one exemplar from a recent work from Clara Abraham, where NOT2 and these TNF as a 15 sort of show interrelations, and antimicrobial activity is one of the key features that drives in particular Crohn's disease. Now, one feature that I was always really intrigued, and that comes again sort of from your work, is that the risk variants are not equally distributed within different populations, but there are clear differences in the allele frequency and in the association degree. between sort of different populations in the world, in particular Europeans and, for instance, here in East Asia, and recent work sort of on Africans from Supra similarly shows these differences. So we are not all equal, there are differences, and of course it's very interesting to speculate what are drivers for this. Now, one question we had is if there are rare variants that that drive disease in different regions of the world as well. And of course, one possibility could be that there are founder effects in rare, very, very small regions, and that could lead to an increased allele frequency of rare variants as well. Now, one of the more striking features over the last 4 or 5 years has been that in particular in Asia, in China, Japan, Korea, there have been sort of some variants that drive a rare neonatal form of inflammatory bowel disease caused by IL-10RA defects. And these sort of rare variants have a surprisingly high frequency. So Dominic Aschenbrenner and Zheng Ye in the lab took on to do a more comprehensive analysis. And they sort of put together all the variants that we knew in terms of numbers of patients, and the majority of the patients are described in IL-10RA defects, and then the pathogenic variants. And then what we often see in rare recessive disorders, if we would plot the number of variants on the X and the Y graph, is that there is the vast majority on the diagonal, because most of these patients are from patients from consanguineous families. If you do this in the IL-10RA variants, then we see a large extent of variants. And we see that there are compound heterozygous variants. And this is often the case if the variants are relatively common. What we then sort of found that only a fraction of those variants have been validated by functional tests, and the vast majority have been not. So we then sort of went on to see where are these variants distributed in the world. And if you do this on a GNOMAD browser, then in East Asia, there is a substantial sort of increase. And this is not just in one region, but we can see this in China, in Korea, and Japan. And then there are certain regions within China that are specifically enriched in these variants. And again, it's not just one variant. There are multiple of these pathogenic variants that are present in this region. Interestingly, these non-synonymous variants, the majority of those are within the extracellular domain. And so there is a clear enrichment in the extracellular domain of the IL-10RA molecule. And if we do a structural modeling, then the vast majority of these variants are predicted to disrupt the molecule and disrupt IL-10 binding itself. Now, of course, if the majority of those variants have never been functionally validated, we have to do this. And so Dominic Aschenbrenner in the lab took this task on, and instead of doing one variant after the other, he validated this for 26 uncharacterized variants. So if we do in a HEC cell assay and phosphostat 3 analysis, the type 1 interferon response is completely normal. However, the IL-10 response is to a variable degree abrogated by these variants. And some of these non-synonymous variants respond like a loss of function frame shift or a stop codon, and some others have a more of a hypomorphic effect. Now, we were then interested to see, is there some balancing natural selection that drives these variants? And one possibility to do this is to do a spatial association study with pathogens that are present in these regions. We did this worldwide. We used a database that captures infectious diseases, 357, and we excluded those with unspecific terms or that were endemic present. And then we sort of did a correlation analysis, and the strongest association we have seen was against Schistosoma japonicum. Now, this is, of course, a very interesting candidate because there are quite a few data available that link IL-10 signaling in this with this pathogen. IL-10 is produced by the parasite, and that stops anti-parasitic immune responses. And it's possible that the enrichment of these pathogenic variants that we see in this region could be a heterozygous effect that modulates these responses. Dominic has done some experiments that point towards this direction. Now, this suggests that there is some balancing selection. Of course, we cannot specifically link this to one pathogen, but there is at least a good candidate. And one question would be whether there are other exemplars present. And Dermot asked me to add on one example that we study for a while. It has been sort of a challenging project. And it started by two observations. One observation is that in Puerto Rico, this little island, there is a huge enrichment in two Hermansky-Putlag variants. One is in the region of 1 in 21, the allele frequency of these pathogenic variants, and the other one is 1 in 32. And that this is just a chance finding is relative moderate. Now, in particular, Hermansky-Putlag syndrome 1, but also Hermansky-Putlag syndrome 3 have been linked to the presence of inflammatory bowel disease, crypt abscesses, granuloma, and a Crohn's disease like intestinal inflammation. So we have started to do some functional analysis on these patients, and we can show that in patient cells and in knockout cells, there is a defective antimicrobial activity present. And this defective antimicrobial activity is linked to an increase in inflammatory cytokines. So Athena Kavanidis in the lab did studies on monocyte-derived macrophages of patients with Hermansky-Putlag syndrome 1, the primary cells. She stimulated those with salmonella and compared this with baseline. And what we do see is that there is a defective or an aberrant lipid metabolism in these cells. And just to cut this a long story really short, is that we think what is happening is that there is a defect in lipid metabolism, in macropinocytosis, in cholesterol metabolism, and that then stimulates mTOR signaling, and that leads to subsequent block in antimicrobial activity. And this has potential impact for antiviral responses. And we currently sort of investigate the possibility that viral responses may have driven this accumulation of these Hermansky-Putlag syndrome 1 and 3 variants about 150 to 300 years ago in Puerto Rico, with this unexpected consequence that there is this enrichment in these variants and inflammatory bowel disease as a side effect of the disease. Now, a last point I want to give in this conceptual sort that we try to put forward, linking the more rare disease genetics and the polygenic patients that we see with inflammatory bowel disease. And in order to do that, Dominic Aschenbrenner and Maria Quaranta did a series of experiments where they stimulated PBMCs from patients with inflammatory bowel disease with multiple IBD relevant stimuli. So muramyl dipeptide or LPS or anti-CD3. And then they investigated the function of IL-10 signaling by adding anti-IL-10 receptor antibodies. And if stimulated with MDP or LPS or anti-CD3, one of the features of the pathways enriched in all of those, interestingly, was that IL-10 signaling came up as a regulatory mechanism. Now, if they did block IL-10 signaling by adding an anti-IL-10 receptor antibody, this did not change major response pattern. However, there were minor changes present, as you can see here, in the difference between the LPS and the LPS plus anti-IL-10 receptor antibody. But when doing the pathway analysis, which genes are really regulated by this blockade and which genes are regulated by IL-10 in multiple conditions, then these were really interesting candidates, because these are genes like IL-23 in particular, or interferon gamma. And we replicated this by a proteome analysis, and the strongest sort of cytokines that are regulated by IL-10 in these conditions are, interestingly, IL-23 or GM-CSF or IL-1 or IL-12 P70 or interferon gamma. So we wanted to understand this pattern. We did single cell sequencing and were surprised to see that even under hyperinflammatory conditions, it's only a small subset of monocytes that produce IL-23, whereas the expression of IL-10 is much more broadly there. And the IL-1 production is nearly ubiquitous under these conditions. Dominic Aschenbrenner went on to do fax experiments, and he could clearly show that IL-10 and IL-23 are expressed by different monocytes. And that is an interesting feature. So even in these strongly stimulating conditions after LPS, IL-10 is produced, but IL-23 is not. If you now block IL-10 receptor, you start to see a population of IL-23 producing cells, but these are not the IL-10 producing populations. Now, of course, this could mean that there is just a sensitivity issue. It could mean that there is some stable expression. So the IL-10 producing cells are a certain subgroup of monocytes, and the IL-23 producers are certain monocyte subgroups. It could mean that we see it just as one point of time. And the, for instance, IL-10 producers subsequently switch to IL-23, or some IL-23 producers switch, or there might be some oscillation in the pattern, and this is a sort of an on and off pattern. In order to investigate this, Dominic and Maria did ELISpot experiments. So she could see a cell type at a certain position and then stain for IL-10 and IL-23 production. And if this would be a stable expression, you would see stable IL-10 and IL-23 producers, whereas if there would be a differentiation effect or an oscillation effect, you would see a shift and some double positive cells. And to our surprise, this was really some stable expression. So there are IL-23 producing cells and there are IL-10 producing cells under these conditions. Now, Dominic wanted to investigate what are the drivers of this IL-23 P19 expression. And so he blocked a number of cytokines that are present in these conditions, or he added cytokines. And surprisingly, this was a relatively specific response. So if you add interferon gamma, you can see more production. If you block multiple cytokines, there is no effect, with one major exception, and that is IL-1. So if you block IL-1 receptor or IL-1 beta in particular, or have a combination of IL-1 alpha and IL-1 beta, then you can abrogate the IL-23 production in a very specific pattern. The rest of cytokines maintains the self. You're not blocking everything. You block a very specific module in these monocytes. Now, one of the questions we wanted to ask is, do we see this type of patterns that we have seen in vitro in patients? We're very fortunate to have the collaboration with Subra and with TED. And to our surprise, again, we saw that there is not a black and white picture, but we could differentiate subsets of patients with Crohn's disease if we did a gene set an enrichment analysis among this large cohort of patients in the risk cohort, including non-inflammatory controls coming from healthy or non-IBD patients, or from non-inflamed ulcerative colitis patients in the ileum. So we clearly see the patterns that we have seen in the Petri dish, this hyper-inflammatory pattern that produced by IL-23, IL-12, high IL-10 production in the presence of IL-1, IL-6, and IL-1 beta. There was a second IL-23 pattern, and this is linked under non-inflammatory conditions with lymphoid follicle production. And we see two different effects. We see IL-23 production, which is very high and well known in dendritic cells, in lymphoid follicles under non-inflammatory conditions. And we see an hyper IL-23 pattern in strongly inflamed patients in the ileum with ulcerating disease, where there is a defect in epithelial barrier function. Now, interestingly, IL-10 is present even in this subgroup. So it's not the absence of IL-10, and it's not the absence of IL-23 receptor, because there are sequencing studies that Dupra and then TED have done. And so these patients are not enriched in defects of IL-10 receptor signaling. So what can explain this pattern? And Dominic could show that if you stimulate monocytes with whole bacteria, you can induce an acquired IL-10 receptor signaling. And this can be shown, for instance, with Salmonella or with E. coli. And IL-23 can induce, if you stimulate monocytes with whole bacteria, so a combination of pathogen receptor signaling. And these can be shown even in the phosphodiesterase signaling. So an reduced responsiveness to IL-10 can be shown in monocytes that are stimulated with whole bacteria, and that is different to just LPS stimulated, and that replicates what we see if LPS and IL-10 receptor signaling is produced, or what we see in patients with defects in IL-10 receptor. So to summarize this, This is, of course, clinically quite relevant. So if we have a defect in the IL-10 or in IL-10 receptor alpha or beta chain, then there is an hyperinflammatory response. IL-23 is abrogated and IL-1 is very strong. Now, from work done in Boston by Dror Cheval, it's even therapeutic option for these patients because blocking IL-1 can resolve intestinal inflammation in these patients. Similarly, we think this could have relevance to patients with subgroups of classical inflammatory bowel disease, because we see exactly in this type of subgroup of patients that has been shown by an expression analysis to respond to IL-23 inhibition, that there is this signature of IL-10 non-responsiveness, and we think this might be due to an acquired IL-10 non-responsiveness in these subgroups. And whether this is, it's probably not a primary defect. It could be that this is due to a very strong combinatorial effect. So it's possible that in classical patients, there is an epithelial defect, that there is, of course, a number of other contributors, but we see at least the signature of IL-10 non-responsive in these patients, and this opens up the possibilities that at least a proportion of those patients might sort of benefit in particular from IL-23 blocking treatments, or even IL-1 modulation effects. So just to summarize, we think we have seen this acquired signature that we would see in patients with IL-10 signaling defects in a subgroup of patients from the risk cohort. We can see this in a subgroup of UC patients as well. With this, I like to stop. I've shown a large amount of work that was driven by Dominik Aschenbrenner, but we sort of are extremely fortunate to have these international collaborations, in particular with the VO IBD group, with Alexio, Christoph, Scott, Dermot, with Judy Shaw. We have worked, and I have not shown this work, with Carl Anderson and his group, really over the large amount of time in the UK. And since we work with extreme rare disorders, we're really fortunate to have an international collaborations with many people throughout the world. Thank you.
Great, Holm. Thank you. Thank you for that tour de force, and it's wonderful to see that picture there, and reminds us that hopefully sometime again in the future we'll all be able to get together and have a beer by the river. That just seems a long way off at the moment, but you know, happy times. So I'd like to open this up to questions. If people have questions, if they could type them in the chat, or just let us know that you want to ask a question, and then we can unmute you. So if anyone has a question there, while people are thinking of questions, Holm, intriguing sort of comments about the Hermansky-Pudliak findings from Puerto Rico, and this suggestion about a viral infection that may have led to the high frequency of the variants that you were discussing. Have you been able to look back, and is there some sort of historical documentation of some viral plague that might have driven this? I mean, this interface between the immune-mediated diseases, infectious diseases is fascinating. And you also alluded to it with the schistosomiasis story as well.
Yeah, so there are sort of some of the records where at least sort of a disease can be linked. So there are simple things like church records. Some diseases are very sort of clearly sort of defined. Obviously, sort of you can only see sort of the strongest, where there is a clear phenotype that we would recognize even in hindsight, and we currently sort of sift through these, and we have one or two candidates. But the interesting thing is that there are clear data, for instance, coming from, let's say, Ebola, where rare disease variants, for instance, in Niemann-Pick type C, another lysosomal storage disease that affects cholesterol metabolism in a heterozygous cell pattern, has a protective effect and reduces the translocation of the virus from the lysosomal particles into the cytoplasm. And although I don't think it's Ebola, there are other variants, and we currently sort of investigate some of those. Some of these obviously will always be speculation, but at least sort of it increasingly informs on this.
Great. Fascinating. Thanks, Holm. So I know that Carl has a question, and we'll come to him in a second, but
we have one question from
yeah.
Anderson.
Yeah.
You're currently unmuted, so you can start speaking.
I'm sorry, Colleen, I couldn't hear you.
So we have Carl Anderson has a question. He's unmuted. You can start talking.
Okay, Carl, you jumped the queue. You go.
Sorry about that, Louise. Holm, great talk. I enjoyed that a lot. And my question's about your analysis, which led to the inference around the balancing selection and the data on the infectious diseases and their distributions globally. Ideally, one would want knowledge of infectious disease distribution globally over time, because of course selection takes place over time. So how strong is the historical data there to allow you to kind of arrive at those inferences about the balance in selection?
Of course, with this argument, you can of course sort of completely sort of take another sort of really valuable sort of argument in. So the only things that we can sort of do now, we could sort of look in the current distribution. We might assume that there is some stability there, but this is of course not a given, as we all know. And of course, it's possible that a disease in historic times, multiple hundred years ago, had a huge impact, and it's just not acting anymore. And that is a clear sort of arguments that we could not at all rule out. There are not good data available, and of course this is a blank. I think it's just a start, and you can always sort of only work with a data-driven approach. What we could try is now, of course, in some of these schistosomiasis, for instance, and go into the increasingly good data, genomic data that China, for instance, is generating, and try to see whether some of the heterozygous carrier have a different immune response. And that is not completely excluded, because these variants are in the region of 1 in 300. So these are common enough to do some of this study with those. So I would, of course, I think this is a problem that we cannot resolve. What we might be able to resolve is to look in heterozygous carriers in the moment and see whether we see a signal there.
Interesting. Thanks. That's interesting.
Great. Thanks, Holm. So Luis's question, Luis, if I butcher this, I'm sorry, but you say in VO IBD, due to IL-10 axis defect, STAT3 signaling is downregulated. Despite the increasing interest in JAK-STAT inhibition in patients with primary immunodeficiencies and IBD, this approach in IL-10 defects might be dangerous. Care to comment on that, Holm?
Yeah, I mean, it's all the right cell at the right time in the right place, and of course it's not all about global JAK stat. I mean, there are different flavors of this, and of course it needs to be all balanced. How much stat is still required for a pathogenic versus an protective response. And the best exemplar sort of that this is not completely probably useless, this approach might come from another rare disease, which is an hyper IgE syndrome. So hyper IgE syndrome are loss of function dominant negative variants in STAT3. And so far, none of these patients have developed inflammatory bowel disease. So the degree of STAT3 is that it's still relevant in these patients to have a protective IL-10 response seems to be more, I mean, the protective in the gut, whereas the Th17 effect that these patients have that drives sort of susceptibility to fungal infection and bacterial infection is clearly there. So from this aspect, I would say sort of it's not all the same, and modulations that affect IL-23 receptor signaling could be substantial, whereas it still does not affect the IL-10 effect.
Great. Thanks, Holm. Holm, so I have another question for you from Michael, who I think has asked the billion-dollar question. Looking at IL-10R variants, most seem to suggest loss of function that are maybe difficult to address therapeutically. So a general question is, are there enough GWAS data to find gain of function mutations that can be addressed by inhibition? And what do you think are the most promising nodes or pathways?
Yeah, I mean, you're all in this room pretty good. Go on, do the experiment. I guess we are all very sort of interested to hear. I can say we have not found sort of found a gain of function variant yet. Of course, I would be delighted sort of to put these variants in some of the assays. What the experiments might show that, of course, one of the questions would be, would exogenous IL-10 be of any help in some of these settings? And the polygenic IBD data would suggest there is already a lot of IL-10 present, and it's just not working. So I don't think that stimulating IL-10 per se is the answer. You need to take away the repression of the system. So, but I don't have data. I would love to hear if you have a variant that is a gain of function. I would love to hear. I don't have any data.
Okay, great. Judy, you've got your hand up.
Thank you, Dermot. That was a wonderful talk, Holm. You really put clearly, I've been hearing about the IL-10RA in Far East Asians for a while, but your 10-23 dichotomy brings up that kind of picture you started with that Carl's postdoc Jimmy Liu constructed on the differences, because the IL-23R, not only is that common variant, the protective variant not present in Asians, but then the common variants have much smaller effect sizes in Far East Asians. So my question is, do we just always start with anti-TNF in moderate to severe Crohn's, or do we think about starting with a blockade of 23 or 1 in Far East Asians?
Things will change. I think also, at least in the monogenic field, we have so much experience that this doesn't work. And so probably sort of the future is really sort of to go faster to either transitioning treatments that avoid surgery and go earlier to stem cell transplantation, or to find approaches that prevent this. And of course, similarly in in the more classical inflammatory bowel disease, maybe some of the approaches sort of on the transcriptomic levels of might lead to, or we already know a lot about TNF non-responsiveness in some populations from work that multiple people have done, and the risk cohort have been sort of helpful in understanding this. And probably some of these sort of data now collectively would suggest to go earlier, of course, with some of the IL-23 drugs into patients. What do you think?
I don't know. I'm asking. You're you're the expert on 1023 dichotomy. So my reflex is I would always just go with anti-TNF first. But is it ethical to do a trial where we start with 23 very, very early? Open question.
At least what the risk cohort suggests, it's not an TNF sort of driven. Because of course, one of the sort of questions is always, if we use one biologic, do we skew the immune system already? And some of the earlier ustekinumab data obviously sort of suggests that the anti-TNF non-responsive ones sort of are more prone to ustekinumab. And the question is sort of, what is it? Do we change biology by using some of the biologics? And at least subsets of risk cohort patients already have this before being treated.
Interesting. Thanks.
Thanks, Holm. I have a quick question just about the PBMC study that you were showing. And you may have mentioned it, and if I missed that, I apologize. How many subjects did you have in that to generate that data? And did you do any selection, or was it just all comers with IBD?
So we have taken all comers. So it's a mixture of Crohn's disease, ulcerative colitis. We could not dissect from our responses most. So it was sort of, we have done the assays between 30 and 50 patients. And you see, and this, so it was underpowered to look for common variants. So we clearly see sort of if there is let's say not two variants, and we see a reduced sort of response to some medication, but surprisingly sort of the biggest change linked to some of the variants was a baseline level. It was not the stimulation. So it seems at least the type of stimulation we have used did override many of the genetic variants, but overall we are underpowered to do this, so it can only, and the data set is available to download.
And it was largely, it was an Oxford-based cohort, so I'm assuming largely European ancestry.
Nearly all European ancestry, yeah, absolutely.
Okay. Yeah.
And adult patients throughout sort of, we had a mixture, and then we sort of tried to understand, but so it's always sort of course, the question having much broader and being powered to do some of the analysis, it was rather a pilot to learn, and we sort of want now sort of to do it more in a broader scale.
Great. Any other questions for Holm or comments? Oh, John. Can you unmute John?
Just quickly, a follow-up to that was, when were these PBMCs taken, like with respect to their disease course or with respect to their treatment? I sort of missed out on that detail.
It was variable. It was sort of incomers into the clinic, and then stimulated sort of in batches to reduce batch effects. And we had 12 different conditions, and it was really sort of to have a pilot, 12 different conditions, broad array expression experiments on all on key stimulation experiments. Now, again, sort of, we did not identify effects, let's say, of azathioprine, other than that the lymphocyte sort of numbers were slightly different. We sort of did wash the cells. We did not see anti-TNF effects. So surprisingly little. The strongest differences are sort of even at baseline present. And some of the changes were the opposite what we had sort of assumed. So the directionality was not necessarily what we had assumed. So yeah, for instance, in NOD2 variants. So there seems to be quite a bit of regulation ongoing, and potentially the hematopoiesis and the cells, the monocytes that enter the bone marrow, are already different by the inflammatory response in the gut, and that clearly affects the readout.
And what about steroid use?
Did reduce this, but because the patients who are on steroids had ongoing inflammation, it might have balanced these effects. So again, sort of, there are opposite effects. The ones who are on steroids are, of course, highly inflamed, and this study was not powered to investigate this, even if we thought we have done sort of multiple conditions on its own. You can have a sort of a plot on all the different conditions, and then only 2 or 3 patients, even per group, are there. We sort of would calculate that we would need at least sort of in the range of 400 plus patients to do this, and to see, even with the strongest drivers like NOD2, IL-23 receptor, ATG16L1 might be better, because there is sort of more common but less of an effect size.
And you wouldn't have in a subset of those patients any idea of what the intestinal lymphocytes are looking like?
No, that is sort of another sort of weakness of this. We have not done it from the gut, and I truly
not as a weakness. It's you know,
that's what the real thing is. So I think to go into the gut to do these single cell approaches on a broader scale than we sort of currently do, and to combine data, and I guess sort of these 10x technologies become comparable, and increasingly we might be able sort of to merge data and to see this not just by the number of cells that are impressive, by increased patients as well.
Definitely. Thanks so much.
Great. Holm, there's one comment for you to comment on, and then a question. So, and then I think we'll wrap it up after that. So the comment first, there's a possibility to use an IL-23 inhibitor such as guselkumab in the future, and maybe use a JAK inhibitor before, topically or orally. Thoughts around that?
What do you mean before?
I presume before using the IL-23 inhibitor.
I don't know. I don't know. I mean, in pediatrics, we always sort of try to learn from you adult gastroenterologists, and then we feel brave enough sort of after some time sort of to go. I'm not the person to comment on that.
We'll try and work it out. We'll let you know, Holm. Okay. Yeah. And then the last question is from David Casero. If I understand well, you relied mostly on single cell expression data to discriminate between steady state, transient, or periodic IL-23 dynamics to rule out post-transcriptional modifications that might have a role in the model. Do you know if those results are recapitulated at the protein level?
That is the next thing. So the really important next thing is to understand this mechanism. So what drives the non-responsiveness, and sort of to look for some of the obvious candidate like SOX, sort of some epigenetic sort of imprinting, obviously an interesting and important, and that's the next stage. Absolutely right. I think there must be a mechanism that is downstream of the IL-10 receptor, and that is most likely a learned mechanism, and that sort of needs to be sufficiently fast. But obviously, even epigenetic mechanisms sort of can happen, but it's a matter of a few hours. It's not just a phosphorylation event.
Great. Holm, people have called in from all around the world, which is testimony to your reputation and expertise in this space, and you have not disappointed. It's been a really outstanding session, first the talk and then the discussion. So I want to, on behalf of everyone, thank you very much for giving your time and expertise. And as I said, it was well worth everyone giving that time. So thanks again.
Thank you for the invitation. Bye-bye.